My screen is up, I am assuming. Rashmi?
Yes, it's up. We can see it.
Excellent. Very good. Well, thank you, Rashmi. Pleased to join and introduce TroClose. As you said, it's a novel 2-in-1 closure device. Provides a new way for surgeons to approach laparoscopy and port site deficits, especially with the challenging obese patient. As everyone attempts to resume what we are going to be calling our COVID-19 life again, our normal life, whatever that new normal may be, many facilities and providers are moving forward and are assuming from this point going forward, because of this crisis, that all patients are COVID-19 positive. So new protocols obviously are being put into place. Some are going to make various changes, from little to great changes, and or following some of the SAGE's guidelines. And just see if I can make a little room here. What we're showing today is a device that will allow for these guidances and changes. TroClose is commercially available in the US and Europe, has been evaluated on over 3,000 patients globally, and it does meet the SAGE's and EAES international guidance. So what is the SAGE's guidance talking about? Well, these are the three that we can find on their website. Incision of port should be as small as possible, clear. Minimizing any kind of leakage, understood. CO2 insufflation pressure should be kept at a minimum, and that pneumo should be also filtrated. All pneumoperitoneum should be safely evacuated via filtration system before closure. This is a key point. And trocar removal, specimen extraction, or conversion to open. So what's the issue with today's devices as we move into, we'll call it our new tomorrow? Well, most of the devices today really have all one thing in common. And the common thread between them is they require a sharp passer in order to present the suture. If you're presenting suture in an insufflated belly or abdomen, it will require also visualization. All are performed at the end of the procedure, when there have been many other dynamics through the procedure itself, which we'll talk about in a second. There we go. So closing at the end of the procedure, especially the last port with visualization and insufflation, can be challenging in obese patients. Patients using a full loop system, which is the common typical way of closing, has its own issues, which can also contribute to post-deficit port pain. Some believe that it's due to the extra tissue tension that's put on these full loop nuts. Bench tested, it shows 75% more tissue tension, which could be a strong indicator as to why many are seeing the extra pain post-op, which obviously changes the patient experience. Another part of the problem is the current closure devices are done at the end of the procedure. At the end of the procedure, there's a variable amount of size difference in the trocar site itself, whether it was because the trocar itself was a 12, whether there was additional stresses put on the trocar deficit due to the length of the procedure and the operation. And this is important because the closure devices of current that use the passers tend to be a lot smaller in diameter. And many are starting to believe that the inconsistencies and the variabilities that are noticed with these devices, they've been around for a long time and they're good devices. However, there has been a note of inconsistencies, and many believe that it's because they tend to toggle inside of these deficits themselves. And as they toggle, that means that the sharp pusher or passer, if you will, has the tendency or propensity to change its trajectory and where it's actually going to end up in the abdomen. So we're all very familiar with surgical smoke. It's obviously become the new normal with our new buzzword of aerosolization. And we've been following surgical smoke for a long, long time, understanding that we are now moving into a better age of filtration devices that are used routinely. These particles now that we are assuming could be COVID positive are something that now requires additional care in the operating room. And I think that's where the emphasis now is on our new protocols that we're starting to see. So some of the aspects that are worth consideration are respiratory impaired patients. We know may not be a candidate for laparoscopy, so that's a consideration. But the case is that we can operate with minimally invasive procedures and protocols. That's a better situation for us to control what's going on in the abdomen. Low pressure is being touted now more so than ever to keep it comfortable for the physician to maintain access, but also lower pressure to minimize trocar leaks and incision leaks, which follows thereafter. Filtration is something that we're starting to hear is almost going to be required as we move forward into the future. Some are talking about disposable instruments and in situ sterilization, which simply indicates that they'll be asking us to, or you providers, to actually clean the instruments as they are taken out of the patient in the operation itself. So what if there was a device that would allow us to set our closure system in place before the procedure? What if it didn't require insufflation or visualization at the end of the procedure? What if it helped us maintain these new guidelines by offering a safe environment for all of the healthcare providers in the operating room, and used a half-loop system which provides 75% less tissue tension, and may also take into account to minimize or eliminate completely capture variabilities. And I think that's really where we're going with this. I'm going to show you a very short video that explains how this automated 2-in-1 system works. Simple assembly, non-bladed tip. Passers present the biodegradable anchors and suture at the start of the case. Remove your obturator. Proceed with the act. There are the anchors. At the end of the case, simply remove the cannula, and the double-tied suture that's attached to the anchors simply fall away from the cannula. So here at the end of the case, simply tie the knot, and you're done. Does not require pneumo, does not require visualization. So this is the TroClose 1200, the 2-in-1 system. The absorbable anchors and suture, just like the Vicryl component. They're PLGA, bladeless tip. So what do we hope to accomplish with this system? Well, we already talked about the half loop offering potentially a lot less post-op pain due to less tissue tension. Anchors are deployed at the beginning of the case rather than at the end of the case. So we hope that with that, we will also not have to present any sharps. The anchors are not sharp, so they cannot do any lower or small bowel injury as a passer might do if you maintain insufflation. There's no chance of trauma at that point. Anchors are deployed and can be confirmed while you're doing the procedure, because now you're doing the procedure, your camera's in, and you can assess the location of your anchors to be ensured that it will close whether you're going to visualize it or not. Port deficits are created by the TroClose system itself. What do I mean by that? Well, we talked about this variability aspect that we sort of learned by the toggle effect that could make these products that are available today inconsistent at best. So with that being said, we are creating the deficit at the time we deploy the anchors. There is no toggle, there's no variability. So as it goes into a fresh abdomen, the anchors and pushers are being deployed. TroClose does not require, as we mentioned, visualization or insufflation at the end of the case. So it's a half loop knot with a lot less tissue tension. So back to the SAGE's COVID-19 guidelines. TroClose today is the only commercial device that does follow the guidelines, as anchors and sutures are deployed in the beginning of the case and does not require visualization or insufflation at the end of the case when you're tired and ready to get to your next patients and leave the room. So very, very easy usability. And that was spelled out in a published clinical study that was just released actually about 15 days ago. And some of the main takeaways was that the usability score was a 4.96 out of 5. So the sutures went where we said they were supposed to go. They tied the way they were supposed to tie. And as a result of this half loop, low tension tissue system, after a year follow-up with sonography, we had 0 hernias on the TroClose sites. I will make this available to anybody who would like to see the rest of it or complete study. I'll show my contact information at the end. Please feel free to contact me directly, and I'll make that available. Coming soon, we have a 15mm port that should be available in months to come, an OptiClose, which will be an optical obturator. And what we're also very excited about is our robotic kits that will be top-loaded onto reposable ports that are used today in robotics. This is a very exciting area for us, as we find that there are lots of issues and complications on those port sites, those reposable port sites. So here, as promised, is my contact information. I hope that we can help in any way to move those that want to move towards the new guidances, not only from SAGES, but just a safe environment for all providers inside of the operating room. Thank you very much. There's my contact information. Please feel free to contact me directly. As I mentioned, this is commercially available now in the US and in Europe. Thank you.